Hi, everyone, and thanks for joining me. This is Z. David Crawford from Grand Rounds in Urology. Joining me is Dr. Phil Koo, who is a regular contributor to Grand Rounds in Urology, always bringing us some very interesting new concepts and information. And Phil is a nuclear medicine physician at the Banner MD Anderson Cancer Center in Phoenix. Phil has been one of the leaders in imaging the PSMA gallium and is going to share with us an overview of this. It's very timely. There was an article just a few days ago in the New York Times about it that got a lot of press. So Phil, thanks for being with us. We appreciate it.
Thank you, Dr. Crawford, for the kind invitation, and also thank you for the very nice introduction. It's a pleasure to be here today to speak about imaging strategies for GU malignancies. And when we're talking about this topic, we're really just focusing on prostate cancer. And it's all about prostate, prostate, prostate. And the reason is because on December 1, 2020, gallium-68 PSMA-11 was approved by the FDA. So this is the first time a PSMA PET agent has been approved for use here in the United States. And it was interesting because the indications were actually a little broader than what I think some people had expected. And the first indication was for patients with suspected prostate cancer metastasis who are potentially curable by surgery or radiation therapy. So this indication is more for patients at initial staging, which is something that's relatively new to us in the field of prostate cancer, especially here in the United States. The second indication was for patients with suspected prostate cancer recurrence based on elevated serum PSA levels. So this is the typical biochemical recurrence space where we've used next generation imaging, which is something we're a little more familiar with, especially since we have years of use with Axumin or fluciclovine. So with regards to the FDA approval, there's a sentence in it that says, clinically, the availability of this information prior to treatment is expected to have important implications for patient care. For example, it may spare certain patients from undergoing unnecessary surgery. So I think there's a recognition of the fact that PSMA PET at initial staging is much better than what we've had. However, we're not quite sure exactly the impact it'll have with regards to patient management and patient outcomes. And we know this because of the trial that Dr. Tom Ho from UCSF presented at ASCO. And this looked at the sensitivity and specificity of PSMA-11 PET at patients at initial diagnosis. And these patients, and typically these are intermediate or high-risk patients, were shown to have overall sensitivity of 44% and 97%. There were actually 5 patients who had disease detected on a PET-CT. However, surgery could not get to these nodes. So originally they were negative on path, but these nodes persisted and these were likely positive. So the data had to be slightly adjusted and the sensitivity came out a little higher than what it was before this adjustment was made. And when you look at the sensitivity of 44%, it's actually pretty high because these are patients who typically have negative bone scans and CTs. So this is really good performance and shows us that PSMA PET is a very powerful tool. And the specificity is very high, which is good. And it tells us that if you see disease on a PSMA PET, there's a high likelihood that it truly is metastatic disease. So it was interesting in their study that they reported that 87% of patients who had true positive disease on the PET actually had PSA persistence. So it says biochemical recurrence after prostatectomy, but I think basically it was PSA persistence following surgery. So I think this gives us a little pause with regards to how best to manage these patients, because I don't think we're quite sure what the answers are here. So when it comes to biochemical recurrence, in the FDA statement, it said that the second trial demonstrated that PSMA-11 PET can detect sites of disease in patients with biochemical recurrence that will provide information that may impact the approach to therapy. So these qualifiers may and whatnot exist in these approvals, because again, it recognizes the fact that we're not quite sure how best to use this information. But there's no doubt that this imaging is much, much better than anything we've had in the past. So when it comes to the question of how we manage these patients at biochemical recurrence, it's really a discussion about our thoughts and our approach to patients with oligometastatic disease. And there have been a few studies, smaller studies, that have shown us early signal that treating patients with oligometastatic disease makes a difference. And one of the earliest studies was the STOMP trial from Pete Oost from University of Ghent. And there's a trial called Saber Comet. And then there's this trial from Johns Hopkins called Oriole. And I'll talk briefly about this Oriole trial. So this included 54 patients, and the endpoint was progression at 6 months based on PSA conventional imaging and symptoms. And what they saw was that in the treatment group, those patients where the oligomets were treated based on conventional imaging versus observation, the treatment arm had a decreased progression at 6 months compared to those that were just observed. And the median PFS was not reached versus 5.8 months in the observation group. 36 of these patients actually had a PSMA PET CT. And what they did was they actually categorized it into two groups. If the PSMA was concordant with the conventional imaging, they called it concordant. However, if the PSMA saw more lesions than the conventional imaging, it was discordant. So in the concordant group, all of the lesions would have been treated with radiation or treatment. However, in the discordant group, there'd be a subset of lesions that were not treated. And what they saw was that when there was a discordance, the performance, the outcomes were worse. So progression-free survival, biochemical progression-free survival was worse in patients where there were more untreated lesions, where the PSMA detected more lesions versus the conventional imaging, and then some of these lesions were left untreated, so they did worse. So I think this provides us even more signal, the fact that having better imaging and being able to treat more of these lesions does lead to a better outcome. And I think this needs to be studied in a larger series to really understand this better. But I think this is very encouraging, and I think for some people provides some more reassurance that they should be treating oligometastatic disease more aggressively. So to go back to imaging, I think it's important to have a overall discussion about what is available and what's sort of in the pipeline. And right now, gallium-68 PSMA-11 was the one that was approved. It's a generic, so it's open for use by other companies or other academic institutions if they'd like to produce it themselves. So that's one of the advantages is any other organization can come up with their way of producing this, and they'll have access to that data, prove that they can make that compound locally at their facility, and they could apply for an ANDA and get approval to do it at their site. So that's one of the advantages. It's generic. It can be shared across multiple different sites. The current disadvantages of gallium-68 PSMA-11 is that the access is limited. Right now, it is only available at UCSF or UCLA. And there's also a question about the supply of gallium-68. Gallium-68 is produced by a generator. It might be able to be produced by cyclotron, but for the time being, the supply of gallium generators might be overstretched. And I don't think we know the answers there, because there are other uses of gallium-68 as well. And this, as we discussed, is already FDA approved. So there is another variation of PSMA-11, which is in a kit form. And the company that is commercializing this is Telix Pharmaceuticals. So the way I like to describe this is it's kind of like a shake and bake method of creating this compound. Because of this, it allows for easier distribution and commercialization because various facilities can purchase the kit. And as long as you have the gallium available to you, you could just put them together and then have that compound to give to patients. I think one of the advantages of this will be price. The fact that it's in a kit form, I think, will allow for hopefully cheaper distribution nationwide. And again, the disadvantage of this is the fact that we do need to figure out the gallium-68 supply for the whole country. And this is currently submitted to the FDA, but FDA approval is currently pending. So then we move on to the F-18 compounds. And there's a lot of excitement about the F-18 compounds because they are of a longer half-life. They're roughly 2 hours in half-life. And that additional hour that a F-18 molecule isotope provides allows for easier commercialization and distribution across the country. Right now, we have the infrastructure in the US to get these F-18 compounds to every part of the country, and we've proven that with FDG. So the company behind this is Progenics, which was acquired by Lantheus. One of the disadvantages here is possibly price. Obviously, we don't know what the pricing is going to look like, but potentially the price of this might be a little higher. Right now, it was giving priority review. So by the end of May, we're hoping to get an answer from the FDA. And it'll be interesting to see whether or not this also gets an approval for patients at initial staging as well. The final F-18 compound I like to talk about is called rhPSMA. It's developed by Blue Earth Diagnostics. And again, because it's F-18, the distribution and commercialization should be a lot better than some of the other agents. The other advantage of the rhPSMA is that it actually uses the same exact molecule for imaging, and they actually have a treatment in the works as well. So what they do is they use the same molecule and they just can trade out the F-18 for lutetium so that so in some ways it is the most pure theranostic because the molecule itself doesn't change when you shift from diagnostic use to therapeutic use. The one disadvantage is, again, might be price. Again, we don't know the pricing, but the commercialization cost might lead to a higher price here as well. And this has not been submitted to the FDA as of this recording. It's interesting to look at the commercial space when it comes to these diagnostic radiopharmaceuticals, and there's been some consolidation in this space. And Blue Earth was recently acquired by Bracco, which is typically a diagnostic radiology company. And this will be interesting because Blue Earth now has a therapy in the works as well. So they'll be able to combine those two. Progenics was recently acquired by Lantheus, which is a diagnostic company. And Endocyte, as we're all aware, I believe 1.5 to 2 years ago, was acquired by Novartis. And Novartis, interestingly, does not have a position in that diagnostic space. So the last piece I'd like to talk about is coverage. Having these agents approved for use by the FDA is a huge step forward. But one of the biggest hurdles to actually getting adoption and use in the clinic so it can benefit our patients is coverage. And right now, there's a lot of unjustified and negative support from insurance companies. And this comes from Humana on November 12th, where they actually were denying coverage for PET-CT for several indications where I think the value of PET-CT has been demonstrated. And I think the quickest and way to destroy all of this excitement and potential to change care for our prostate cancer patients is to deny coverage. And I think anyone who's familiar with this field would wholeheartedly say that this imaging is taking us to a new dimension. And to deny access to our patients to this would be just terribly unfair and unjust. And I think it's something where we need to rally together, not as specific specialties, but as a prostate cancer community to make sure all of our patients eventually have access to PSMA PET-CT. So here's my summary slides, and we're going to talk about unmet needs. The biggest unmet need is really outcomes data. And I think we are seeing early data about the impact, but we need to continue moving forward and getting more data. And it's encouraging to know that groups around the country and groups around the world are currently doing this. We need better outcomes data at patients for initial staging and better patients at biochemical recurrence, which is really going to focus around the space of oligometastatic disease. Another question is how best to pair diagnostic PSMA with therapeutic PSMA. Obviously, there's a lot of excitement about the future of lutetium-177 PSMA to treat patients with advanced prostate cancer. The question becomes, how do we use the PSMA tool? Obviously using the diagnostic PSMA to determine whether they have PSMA expressing disease is important, but I think there's extra levels of information that is there that we can harness to make sure the therapy actually becomes much more impactful. A third unmet need is really starting to think about imaging beyond just a binary tool where we detect disease or we don't. The idea of using imaging to detect treatment response is feasible. I think we just need to study it more. We also should start looking at imaging as a biomarker. What is the prognostic information offered by PSMA PET-CT? And this is all very exciting stuff that, again, we're just scratching the surface. So I think it's important to stay tuned. And this is all going to change the future clinical trial design. Obviously, we've had bone scans and CTs for decades in our clinical trials, and we have great data using bone scans and CTs. But now that this is becoming the future of imaging, it's important for us to figure out ways to incorporate this into our clinical trial design, just so we have the best and most pure clinical trials to demonstrate the best outcomes in our patients. So thank you very much for your attention, and happy to answer any questions.
All right, Phil, thanks. Thanks very much. That was a great presentation. Just a couple of questions about the imaging. And do you think that 5 years from now we're going to be using something like this rather than technetium, just right out of the starting gate for imaging in patients, or not?
Conceptually, I would say yes. But
Mhm.
knowing how change in healthcare moves at in many ways a snail's pace, I would say it might take a little longer to sort of change certain habits. And I think there'll still be people who will rely on the bone scan and CT. But I think there still will be value with bone scans and CTs in certain patients. And it's difficult to answer that question because I think the economics and the finances need to be discussed as well. So Michael Hoffman from Peter MacCallum, recently published data about the cost effectiveness. But in Australia, the price of a CT and bone scan might equal the price of a PSMA. That might not necessarily be true in the United States, where I imagine the price of a PSMA PET CT will far exceed the costs of a bone scan and CT. In which case, we do have to come up with our own equation with regards to what the true value of that test is in our patients. So it's a complicated question, but there's no doubt performance will be better, is better.
Yeah. The other thing that I've noticed in some patients is that a lesion is noted within the prostate at the time of imaging, and big deal. But I wonder in the future if that's going to be a way to isolate areas in the prostate, with very accurately, and maybe even hook up a theranostic or something to it and have sort of one-stop shopping.
I think there's potential there, and there's work being done with PSMA to evaluate local disease. The one word of caution I have is that PET-CT is not a microscopic imaging tool. And these positrons that end up localizing to these sites, they actually travel a certain distance before they undergo what we call an annihilation reaction, which is
Mm-hmm.
what allows us to image that activity. So the image resolution, the resolution of actually where the activity originates from, isn't pinpoint accurate. And if that's the case, we just need to understand the limitations. So if we start looking at lumpectomies in the prostate, I think we just need to take wider margins, perhaps, if we can get to the point where we are sure about the performance to evaluate local disease.
So how do you think it compares to MRI? There's a lot of interest, as you know, right now in targeted focal therapy and ways to annihilate the lesion in the prostate, the male lumpectomy, and uh, uh, and I'm just wondering if this is a technique to give us a deeper dive and interrogation of the prostate, so that if there's other lesions, satellite lesions or something that are out there, we can go after them. Are you saying that the resolution is such that it's not going to be that accurate, or?
So the resolution is such that there's a limitation with regards to how small lesion it can detect. And MRI, this image spatial resolution is better with MRI than it is with PET. But there's an advantage with PET because it's physiologic. So there's
Right.
that localization in the actual prostate cancer cell that MR doesn't have. So to me, if I look into the future, I think the holy grail is PET MRI. So if you could inject PSMA, do the PET acquisition, and also get an MRI, then to me, you have almost like the ultimate multi-parametric MRI to help make sure we do the male lumpectomies most accurately. So I think that's, but the problem is PET MRIs are expensive. That's a whole nother discussion.
Right. Particularly like during your presentation, you were talking about a number of the insurance companies not covering the new stuff.
Yeah.
It may take a while. Phil, thanks. As always, the information you share is much appreciated by our audience, and we hope you have a great holiday season.
My pleasure. Happy holidays to you as well. Thank you.